everyone, and I welcome you all to the 107th session of e-NISCHIT, HIV, our collaboration with NACO, and for the HIV strengthening of learning for HIV/TB. I welcome all the ART centers present here. A very warm welcome. And I'm Dr. Ananya Prabhu, and with me is my team. That's Dr. Jyoti from Share India. And from Eco India, we have Manjeet, who's looking after the IT, and Shifa from the Project Eco. And I welcome you all on behalf of all of us. So today is going to be a very important case discussion, because what we are going to deal with today is a very common problem, yet a very, very significant. In fact, the most significant challenge that we face in our ART clinics, that's of non-response or recurrent TB or relapsed TB, when we are just too confused and too exhausted that what went wrong, why is it not going away when we are giving the medicines. So for this challenge, we are very, very fortunate that we have with us on our panel today our esteemed expert, Dr. Lokender, sir. He's a very senior chest specialist, and he has multiple decades of experience in tuberculosis, and he'll be talking us through this challenge. Thank you, sir, for joining us today. It's a privilege to joining us. And the case discussion will be done by case presenter Dr. Tanweer Ara, who's a medical officer, GTB Hospital. So I thank Dr. Tanweer Ara for sending us your case and helping us in this standard.
Good afternoon, everyone.
Yes.
Thank you so much to all of you. This is my second time I'm presenting case, and I have a wonderful experience during last session also, ma'am. So I must say, e-NISCHIT is a very good platform for all of us, that we can discuss our all doubts, and we can improve our knowledge. So I think we are lucky to have this kind of platform, and definitely we can improve our quality care of patients. So once again, thank you so much to all of you, ma'am. This is case of a 27-year-old male. His ART number is 7872. And date of ART initiation is 27th February 2019. It's by mistake, it's written 5th March. It's the date of ART initiation, 5th March 2019. And his baseline CD4 is 468 on 28th February 2019. His second last CD4 is 470 on September 2019. His last viral load is TND on August 2022. His LFT KFT is within normal limit. HB is 13.8. Now I'm coming to the history. This patient came for ART visit for ART medication. In January 2021, he complained about right side lower back pain, general weakness, loss of appetite, and burning micturition. So that's why we advise for urine RM test and ultrasound whole abdomen. When he came in next visit, he came with only ultrasound whole abdomen, not urine RM test. But his USG abdomen shows small calculi with cystitis. That's why we started antibiotic course for UTI and advice for plenty of fluid, and also advice for urine culture before antibiotic course. After antibiotic course, in next visit, patient symptom improved, like burning micturition or fever. But again, in next visit, after 1 month, patient complained about fever, severe lower back pain, and lower limb numbness. So we advise him for MRI spine and refer to ortho-OPD. In next visit, when he came with MRI report, it showed infective spondylocystitis at D9, 10, D12, and L1. Also, there's a collection at D9 to D11 level. That's why we initiated ATT on 16 March 2021. He has taken almost 1.5 year ATT till 18 CP. We again advise for MRI spine. When he came with MRI spine report, it shows collapse of D9 and partial destruction of D10 spondylocystitis involving D9 to D10, knuckle deformity at D9, Also pulmonary nodule in posterior basal segment of right lung with focal pleural thickening. But this time patient symptom improved, not so much severe back pain, only slight numbness of both limb. That's why, because patient already taken 1.5 year. So we stopped ATT on 30th August 2022. Again in next visit when he came for ART medication, he came with swelling of left side of neck. There was a big swelling. Then we refer for FNSE test. His 2-time AFB was negative, and also his CB-net was also first CB-net was also negative. But when we advise for repeat FNSE, the third time it shows granuloma and suggestive of TB. That's why, because this is the second time, and within 1 month, we advise for LPA also, and restart ATT on 25th November 2022. He has taken 9-month ATT, but during these course, patient couldn't get LPA report. This is one of the problem we are facing with LPA report. LPA report is not, they are not giving very soon, like it take sometime 1 month, 2 months, 3 months. So patient got fed up and he never came back with the LPA report. But after 9 months of course, patient lymph node totally suppressed. Symptom was also improved. So that's why we decided to stop ATT on 29 September 2023. My concern is because after 29 September, patient again came back for ART clinic, ART medication on November, December, January. All 3 months, patient have complained on, about lower limb pain and numbness. And this time, the January visit, patient again complained for lower back pain also. So my concern is, can we advise again for MRI of a spine? And what if MRI spine again showed any sign of tuberculosis? How we will know is there any resistance of TB, because patient already taken 2 times ATT, more than 2.5 years. So how do we know is there any resistance of ATT? We don't know LPA report also. And one more thing, a patient, we advise for basic exercise for lower limb numbness. So I'm thinking, can we advise for exercise physiotherapy? Is it dangerous for patient? Because last his MRI showed destruction or at D10 also. So is it suitable for Pott spine patient to advise for exercise? This is my few questions which I want to know, sir. This is one what I need to explain. And his last regimen, ART regimen is TLD, because we stop ATT. So only TLD regimen right now. But during course of ATT, we have given extra DTG 50 mg. Thank you so much, ma'am.
Thank you, Dr. Tanweer. Thank you for discussing the case, and you said everything very clearly. So as you explained, Dr. Tanweer, that patient, one thing I want to understand, is there any information about whether patient was compliant for the 2 years that he was started on ART? Was he compliant on his treatment, or was he irregular on his treatment?
Yes, he was regular, ma'am. I'm waiting for last viral load report because
he had a very good viral load of 468. So
29th August 2022, but he didn't get viral load in 2023 because I don't know what happened with him. Whenever he came, he said, okay, next time we will do. So this time I'm strictly advising for VL and fresh CD4 report also.
Okay. Because the only concern was that when he started off, he had a good CD4 count. So whether he was compliant on ART, and whether that maybe he was not compliant, and that's why he got into such severe case of Pott spine or extrapulmonary TB. So that was also an important history here, that how compliant he was with this ART medicine. Otherwise,
he was on ART medication strictly, and more than 95% his adherence was very good.
Okay.
He came on time every visit.
Okay, that's a good information to give. That means it was not ART failure and something more related.
No.
Okay, so the patient he was 2 years on ART, and as you said that he was more than 95% compliant on it. Then in January 2021, he came with us to you, and he was investigated with because he came with loss of appetite and burning micturition, and he was given an antibiotic course, but his symptoms improved, but again he complained, so then he was advised MRI. And in the next visit, when he came with MRI and it showed infective lesions, that was a time when you people on clinical radiological collaboration decision you took, and you started on ATT. There was no microbiological evidence, but
No.
on the clinical radiological evidence, you took the decision. Okay,
Yes,
and he took the ATT for 1.5 years.
one
So
and a half year.
and I believe he was compliant then also on ATT and ART as for
Ma'am,
those
yes.
1.5 years.
Both drugs he was taking on time and he was coming on time. No problem with adherence.
Okay. And but in spite of being adherent to the treatment, and in spite of being given the quality drugs and the right drugs, he deteriorated, and his MRI showed destruction and changes suggested of residual active pulmonary tuberculosis diseases. So then he took this, and then when he again patient symptoms had not improved, and there was numbness in lower limb as well. You had to stop the ATT in
Most
August
common
2015.
problem, ma'am, whole all over. I think the 2.5 year, half year, he always complain about lower limb numbness. That's why one of the time when I advise for physiotherapy also, but right now I'm thinking should I advise again him for physiotherapy or no? Because numbness is more bothering to the patient. He said, yeah, okay, there was a time when I was sleeping in night and I feel there's no legs. So this is the most important thing I want to know, ma'am.
Okay, so did you give any extra medicine for any neuropathy medicine that generally we give, like amitriptyline? Did you add on any such medicines on that patient? Or you're just
He
getting
gabapentin for pain relief, gabapentin, and multivitamin like methylcobalamin also. I have already given him.
okay, he was getting gabapentin and
Yeah.
for neuropathy. Okay. Okay, that's good to know. So next time he had a swelling, and
It is
this
relief.
time he was
Somehow pain is relief, but numbness is still persisting.
okay. Okay, I understand your point. So next time he was like having swelling, and you did FNSE, for which LPA was sent, and patient was restarted on ATT. But unfortunately, that LPA report didn't come through, right?
No. LPA is very difficult for us to get on time.
Okay, so that's one programmatic disadvantage maybe. But yes, the LP report would have been very, very important in this case. So the patient history we have now understood very well. So now we need to go, we will go to the dietetic and try to understand what reasons could have been for this kind of a clinical picture. So I invite Dr. Lokender sir to please tell us the talk. Thank you, sir.
Okay. Good afternoon. Good afternoon, everybody. As you know, if you summarize the case, patient is on ART since March 19, and he was advised MRI spinal to confirm the tuberculosis is 16/3/21, and ATT was started on March 21 till 30th 8/22, almost or more or less or more than 17 months. So CB-net must be in the lymph node. By mistake वो ऊपर चला गया है, लेकिन ये lymph node के साथ lymph node में आपने बताया कि 2 बार FNAC हुआ है, and in which the AFB now was negative, but third time it shows the granuloma suggesting of tuberculosis. So you restarted the anti-tuberculosis treatment November 22 till September 23. It's approximately 9 months.
Yes.
थोड़ा सा आप मुझे बता सकते हैं why did you extend the tuberculosis treatment till 9 months?
Because after 6 months, his lymph node was not totally suppressed. There was a small. I felt when I press his lymph node, I felt somehow it's. I can feel his lymph node. So I extended another 3 months also.
Okay. And we did not have any LP report.
No, sir. Till now we are waiting for this, but patient now he is not interested in LPA report. He is coming back without LPA report.
So our case is a bone TB followed by lymph node TB.
Yes, sir.
So this is the case of extrapulmonary tuberculosis because it does not involve any lung lesion.
Yes, yes, sir.
So as I read from your case presentation, the issue of discussion is recurrence of tuberculosis after ATT stop.
Stop.
Am I right?
Yes, sir.
Okay. So I am Dr. Lokender from NITRD. So we are discussing the case of extrapulmonary tuberculosis. Site is bone TB and lymph node TB. Next, please. Before starting my talk, there is some epidemiologically should be know everybody that the global report 2020 they said the 16% tuberculosis is extrapulmonary tuberculosis among 7.5 million case globally and 19% in Southeast Asia. So because our case is a skeleton tuberculosis, the 1 to 2% of all TB case and 10% of extrapulmonary tuberculosis. आप समझ गए सारे टीबी केस के अंदर से स्केल्टन या बोन टीबी 1 to 2% होता है और सारे एक्स्ट्रा पल्मोनरी ट्यूबरकुलोसिस के अंदर 10% स्केल्टन टीबी होता है एंड ऑल स्केल्टन ट्यूबरकुलोसिस के अंदर 50% स्पाइनल ट्यूबरकुलोसिस होता है जो हमारे केस में भी सो स्पाइनल ट्यूबरकुलोसिस इज द कॉमनेस्ट बोन टीबी नेक्स्ट इज lymph node. The lymph node, as all of you must be knowing that is the higher rate 30.8 per lakh in 2013 and up to 14 years it's 4.4 by 1000. Extrapulmonary tuberculosis include usually among HIV. Although extrapulmonary tuberculosis occur in any patient or any person, but more commonly it occurs with HIV TB. Below that, I have write down the paradoxical reaction. I will discuss this in later on, but you just to remind you that paradoxical reaction is the immune reconstitution inflammatory syndrome, which is known as IRIS, may occur 10 to 15% patients. Usually, culture negative do not represent the treatment failure. Paradoxical reaction is IRIS. आई थिंक जितने भी लोग HIV में काम कर रहे हैं उनको शायद ज्यादा बताने की जरूरत नहीं है कि पैराडॉक्सिकल रिएक्शन क्या होता है द इम्पोर्टेंट इट जनरली इट मे बी यूजुअली और टर्न आउट टू बी ए कल्चर नेगेटिव बट ये ट्रीटमेंट फेल्योर नहीं कहलाता है डू नॉट रिप्रेजेंट ट्रीटमेंट फेल्योर नेक्स्ट सो to be on to simple the things as we had our case RNTCP has classification on the basis of history of previous TB treatment. So as we have what do you say spine tuberculosis which was the first time it developed. So spine TB was new case. It still comes under the heading of new case, which is not with the history of previous TB treatment. The new case definition is a TB patient who has never had treatment for TB or has taken anti-TB drug for less than 1 month. मतलब जो भी पेशेंट ने दवाई ली है वो या तो 1 महीने से कम हो या दवाई टीबी की कभी ली ही नहीं है पोस्ट केस नया केस है ये है हमारा पहला when patient developed the bone TB means he was the new case as per RNTCP classification. When we classify on the basis of history of previous TB treatment, the recurrent tuberculosis, the TB patient previously declared as success treated, cured or treatment completed, and is subsequently found to be microbiologically confirmed. See, as you ask us the recurrence of tuberculosis after stopping ATT, see the definition of recurrent tuberculosis. हमारे पेशेंट ने बोन टीबी का इलाज किया, पूरा इलाज किया, एंड ऑफ द ट्रीटमेंट हमें शुरू में भी नहीं पता था कि वो पॉजिटिव है, कंफर्म नहीं था, और लास्ट में भी हम कंफर्म नहीं कर सकते थे, इसलिए इट्स डिक्लेयर एज ट्रीटमेंट कंप्लीटेड. बट टू से रिकरेंस और रिकरेंट, it should or he or she should be microbiologically confirmed. Yes. जो भी पेशेंट की पास हिस्ट्री है और वो आपके पास दोबारा आ रहा है, उसका कंफर्म होना चाहिए, तभी हम रिकरेंट और रिकरेंस कहेंगे. बट देयर इज अ स्मॉल डिफरेंस, रिकरेंट एंड रिलैप्स. What is recurrent tuberculosis? Is more than one TB episode per patient and is caused by reinfection with the new TB strain. What it says? The new TB strain. Whereas the relapse with the previous strain. जो strain से पहले से ही TB थी, उसी के डेवलप होने से रिलैप्स कहलाता है, और अगर नया टाइप का स्ट्रेन है तो रिकरेंट कहलाता है. So it's a very difficult to differentiate recurrent and relapse. Microbiology can do it, but this is for the academic purpose कि आपके पढ़ने लिखने और समझने के लिए difference is recurrent and relapse is there. Treatment after failure, those patients who have previously been treated for TB and whose treatment failed at the end of their most recent course of treatment. Treatment failures means पहले वो टीबी की दवा चल रही है, उसकी चलती जा रही है, बट आपके पास कोई भी रिपोर्ट उसके नेगेटिव कहने के लिए नहीं है जब आपका टीबी का ट्रीटमेंट बंद होता है. ठीक, तो आप उसको, या फिर वो साइमल्टेनियसली पॉजिटिव हो जाता है, तो दैट इज नोन एज ट्रीटमेंट आफ्टर फेलियर. नेक्स्ट इज ट्रीटमेंट आफ्टर लॉस टू फॉलो. A TB patient previously treated for TB for 1 month or more than 1 month and declared loss to follow. Then again he came to you and subsequently he found to be a microbiologically confirmed TB case. Means AFB should be positive. If you see the definitions, one is the recurrent TB, second treatment after failure, and third is a treatment after loss to follow. One more classification is there known as other. What is other? Other is previously patient are those who have previously been treated for TB but who cannot be classified into any of the above classification is other. See, in this case, patient was treated for bone TB. After few months, he developed the lymph node TB. Means previously he had history of anti-tubercular treatment, but we are not able to confirm the diagnosis. As you said, you have sent the FNEC for AFB, which is negative. CBNet is also negative, and the diagnosis was made on granulomas basis. So our case, patient to be classified new case to others. Next. As you ask for how this pathogenesis is developed in the spine TB and lymph node. Similar to other and extrapulmonary tuberculosis, it is spread by hematogenous followed by lymphatic or contagious spread. Although the primary site is lung, you may get the lung lesion and then you may get the spinal tuberculosis or bone TB, whatever. But it is spread by hematogen. Whereas in the lymph node, we have a various portal via respiratory tract by hematogenous or lymphatic disseminated, usually involve the hilar and mediastinal lymph node. via tonsil is spread via the lymphatic to cervical lymph node. It is postulated that the cervical lymph node occur as a result of TB infection of tonsil, adenoids, and Walden's rings. Whereas the mediastinal lymph node, enlarged lymph node, cause compression of major blood vessel, phrenic and recurrent laryngeal nerves, or cause erosion of the bronchus. By that, they spread to the other side of the body. And whereas the lymph node in abdomen via swelling of sputum or milk infected with the MTB or M. So this is the slide in which we say how the lesion is spread in different part of body. Next. So although spinal TB has classified into 4 types based on location within the vertebra and the lymph node, Jack and John also classification has the classification for the stage of, although we do not practice it, but just for the sake of academic knowledge, the spinal TB is classified into 4 types. One is paradiscal, most common variety due to anterior spread. This can adjust paradiscal body of the supply by the same end. Spinal TB central due to venous spread. Anterior is subperiosteal spread or appendical, and posterior is least common structural instability of the spine. And we day and night used to see the lymph node, but we never ever classify into the stage of the lymph node. Most of the time, we just write down the lymph, positive or negative. Although they have a classification stage 1, 2, 3, 4, and 5. Stage 1 is reactive lymphadenitis, enlarged, which is enlarged lymph node, firm lymph node, mobile, discrete node showing non-specific reactive hyperplasia. Whereas in stage 2, periadenitis, large, rubbery node, and fixed to the surrounding tissue. I think you must be having the either reactive lymphadenitis or periadenitis in our case. If you will not treat this lymph node, they may convert into cold abscess, collar, and sinus tract formation. So these are the stages of lymph node. Although we do not do the stages, we just write down the sinus tract positive, cold abscess, lymph node positive. Stage 1, 2, 3, 4, we do not try. Okay, next. Question arises when to suspect. As you said, simple is the constitution symptom. I think all of you know, no need to explain. In HIV, if you have any one of them, current cough, fever, night sweat, or weight loss, you can suspect it could be a case of tuberculosis. In spinal TB, or should be suspect in individual with persistent localized pain, localized pain for more than 4 weeks. हमारे पेशेंट के पास भी 4 हफ्ते से ज्यादा का उसने पेन बोला, बैक पेन बोला है, उन्होंने फीवर भी बोला है, कॉन्स्टिट्यूशन सिम्टम भी है और वो भी है, बैक पेन भी है. So we can suspect this could be a case of bone TB. Now question arises, how we can diagnose a case of bone TB or lymph node TB. See, RNTCP says either AFB confirmed case or second is clinically diagnosed case. Confirm means AFB culture, CBNet positive or direct smear if chest is involved. In extract pulmonary tuberculosis, most of the time we deal with the clinical diagnosis. So as far as bone is concerned, it includes symptoms and sign of bone TB, plus you should ask for X-ray, CT MRI, and surgery if required. So extrapulmonary tuberculosis, if bone is involved, the modality of investigation is to diagnose a case of bone TB is X-ray of site, MRI, or surgery if required, or further if you want to have a tissue, you can have biopsy. by consulting the consult specialist doctor. In case of lymph node, हम लोगों को उसमें भी कोई नेगेटिव पॉजिटिव नहीं मिला. AFB was negative, CBNAT was negative. So clinical diagnosis of lymph node include, because it's not a positive, so we made a diagnosis on clinical basis, symptom and sign of lymph node. If they have a negative microscopic, negative culture or CBNAT is negative, no other diagnosis explains sign and symptom. जब आप कोई और diagnosis को नहीं explain कर पाते हैं, then radiological evidence suggestive of lymph node. Somehow you may get the lesion in the lung also, and histological finding and clinical features suggestive of tuberculosis. By these 4 points, clinical diagnosis or sign symptom of lymph node plus any one of them is which you can think of, that is the case of lymph node tuberculosis. So conclusion of this is finding of caseating granuloma on histopathology with constitutional symptom is highly suggestive of tuberculosis. So histopathology में आपको granuloma मिला है, symptom उसके पास है, तो as you have done started the ETT, so it also says the ETT may be indicated in such case even in absence of माइक्रोबायोलॉजिकल एविडेंस. मतलब कि अगर आपका टीबी कंफर्म नहीं भी हुआ है लेकिन हिस्टोपैथोलॉजी में और साइंस सिम्टम्स आपको ऐसा लग रहा है कि ये टीबी हो सकता है, तो आप उसको टीबी की दवाई दे सकते हैं. नेक्स्ट. So once we are dealing with the bone TB and lymph node TB, if patient is drug sensitive TB, you have to give them a 2 months of RHZ followed by 4 months HRE. Or if you have a bone TB, then 2 months of HRZD followed by 10 months HRE. See, for lymph node, you have to give 6 months, but you have gave to the up to 9 months. It means कि आपने 3 महीने थोड़ा सा एक्स्ट्रा दिया है, जो आपने रीजन बता दिया है, इट्स ओके. बट बोन टीवी के लिए 12 महीने देना ठीक था, लेकिन उसको भी आपने बढ़ाया हुआ है 18 more than 18 months. इट्स ओके. आई थिंक आपने ऑर्थोपेडिक्स वालों से कंसल्ट किया होगा टू एक्सटेंड द एंटी ट्यूबरकुलर ट्रीटमेंट. डॉक्टर
Tanweer.
Yes, ma'am. Actually, Safdarjung Hospital Orthopedic Department, they advised to extend till at least 1.5 years. That's why I have extended 1.5 years. And another 2 months taken because patient didn't get MRI repeat test. That's why we are waiting for MRI report. So we extended another 1-2 months is taken because of MRI report.
Okay. So the treatment of lymph node and bone TB is 6 months and 12 months. You can extend. There is some possibility also.
Lymph node was not suppressed totally. That's why I extended another 2-3 months.
Yeah, I got it.
Not totally suppressed.
Yeah.
Totally.
If patient develop the RIF resistant or MDR tuberculosis, you have to have a shorter regimen. I am not going to detail it. Or second is the all oral longer regimen. There, as per NTCP, there are certain inclusion and exclusion criteria to start the shorter regimen or all oral longer regimen. If required, you can ask for the surgical intervention of the respective spasm. Question is, what is the difficulty to manage the bone TB or lymph node TB? For bone TB, orthopedic doctor should be involved, irrespective of recurrent, fresh case or relapse case. As far as lymph node is concerned, lymph node में हम लोग तो फिर भी थोड़ा बहुत देख लेते हैं. But what difficulty is the appearance of new lymph node or enlarge the existing lymph node, develop the fluctuation, sinus tract or residual lymphadenopathy after completion of treatment. See, there is an appearance of new lymph node and enlargement of existing lymph node. Consider on 2. My next slide says what? Next slide. appearance of new lymph node or enlargement of existing disease. I think आप सब लोगों को पता होगा immune reconstitution syndrome iris. What is that? The TB is defined by the clinical or radiological worsening or pre-existing TB lesion or the development of new lesion. जो मैंने इससे पहले वाली स्लाइड में पहले दो कारण बताए थे जिसमें डिफिकल्ट टू मैनेज द ट्यूबरकुलोसिस था, उसके अंदर ये दोनों चीजें आ रही है. ड्यूरिंग द एटीटी, आप एटीटी देते हुए नया लीजन आ जाए या पुराना लीजन बढ़ जाए, इज नोन एज आइरिस. Most commonly seen in HIV cases. Diagnosis, you have to make the diagnosis by exclusion. It's occur 10 to 15% of patient. Usually culture is negative. Once again, I am emphasizing, do not represent a treatment failure. Do not represent treatment failure. So it's a self-limiting, may cause a serious morbidity also. Rarely it cause the death also. So deterioration in the first 3 weeks to 4 months is the paradoxical, maybe due to the paradoxical reaction. Most commonly in HIV infected, usually within 2 months of some combination of ART. If you want to manage this symptomatic treatment, continue ATT, assure the patient, and USG guided aspiration if fluctuation is there. So 3 वीक से लेके 4 महीने के बीच में आपको लीजन बढ़ा हुआ भी मिल सकता है, नया भी मिल सकता है. और एआरटी पर अगर पेशेंट है तो 2 महीने के अंदर अंदर आपको इस तरह की कोई रिएक्शन मिलती है तो आप उसको एक बार के लिए आइरिस के बारे में जरूर सोचें. ये स्लाइड केवल आइरिस को बिकॉज डिफिकल्ट टू मैनेज के अंदर दो चीजें हैं जिसमें बोला जाता है कि अपीयरेंस ऑफ द लिम्फ नोड और न्यू लीजन ऑफ द लिम्फ, अपीयरेंस ऑफ द एग्जिस्टिंग increase of the existing lymph node or lesion or the new development of the lesion. So within 2 months of the ART, you should think of iris. Next is, this is your questions. Your question, difficult to manage the bone TB and LTB. The possibility explanation for this suboptimal response of therapy जो आपने 9 महीने बढ़ाया है और जो आपने more than 18 months or 17 months बढ़ाया. Possibility explanation, poor patient compliance जो डॉक्टर अनन्या ने आपसे पहले पूछी है कि whether she took the she was adherent to the treatment. Or next is unidentified drug resistant. We don't know because we are not able to confirm whether it is a tuberculosis positive or not. Poor drug penetration and absorption may be there. Local site का environment, we don't know because you said कि जो Pott spine है उसके आसपास भी थोड़ा सा residual था. NTM, patient may be suffering from NTM. That's why she or he may not respond. So superadded infection, drug resistant with INH or MDR. And last not the least, once you are not able to diagnose and you think this could not be a case of tuberculosis, then for lymph node you can think of malignancy, lymphoma, leukemia, etc. So once you diagnose the case, you start the treatment, you faces the difficulty, then you have to follow the patient at the 1, 2, 4, and 6 months. The possibility of treatment failure is patients who have worsened or deteriorated after initial improvement. Development of fluctuation, repeated imaging may be repeated if clinically indicated, and you have to see the sinus tract if it is there. Now your question, the obtain prompt sensitivity testing in relapse or non-responder and chemotherapy modified accordingly. अभी भी आपके पेशेंट को रिस्पॉन्ड नहीं आ रहा है या आपको लग रहा है रिलैप्स है या रिस्पॉन्ड नहीं कर रहा है तो आप हमेशा उसका सेंसिटिविटी पैटर्न लेने की कोशिश करें. इससे आपको क्लासिफिकेशन में बड़ी आसानी हो जाएगी. as you said, the lymph node का extend करने के criteria में जो RNTCP guidelines है, अगर आपके lymph node, if lymph node size remain more than 1 centimeter at the end of treatment, it may be partial responder, may extend RHE for 3 months, जो आपने किया है. आई होप कि उसका lymph node का साइज भी बहुत ज्यादा 1 सेंटीमीटर से नीचे नहीं होगा, तभी आपने इसको एक्सटेंड किया होगा. और फॉलोड बाय बायोप्सी ऑफ और हिस्टोपैथोलॉजी एंड टीबी कल्चर. जब भी आपको उसको एक्सटेंड करना है तो ट्राई करिए कि उसकी हिस्टोलॉजी हो पाती है कि नहीं है, उसका कोई पस है तो पस को खींच के उसको कल्चर के लिए भेज सकते. अगर लेस देन 1 सेंटीमीटर, दिस इज नोन एज रेजिडुअल फाइब्रोटिक lymph node, ATT नीड नॉट टू बी एक्सटेंड. अगर ये आपके केस में 1 सेंटीमीटर से नीचे था तो आपको आईटीटी एक्सटेंड करने की जरूरत नहीं भी थी, तो नहीं कर सकते थे. लेकिन अगर 1 सेंटीमीटर से ऊपर था तो आप एटीटी 3 महीने के लिए बढ़ा सकते हैं विद कंसल्टेंट. विद दिस नेक्स्ट, so to define our case definition wise is the clinically diagnosed TB case, not confirmed, based on anatomical site of disease. This is known as extrapulmonary tuberculosis. So pulmonary tuberculosis was not involved. If pulmonary and extrapulmonary tuberculosis is there, then you have to labelize pulmonary tuberculosis. So second time when he developed the lymph node, so he had a past history of ATT. Based on past history of TB treatment, patient is labeled as others because he is not recurrent, not relapse, not treatment after failure, as we discussed in one of the our slide, and not a loss to follow. Most of the time, all has to be confirmed, microbiologically confirmed, then only you can label treatment failure, recurrent or recurrence. So our confirmed patient is clinically diagnosed extrapulmonary TB, which is categorized as others. You can mention the site, bone and lymph node, not a recurrent or relapsed TB case. With this, I finish my talk. Thank you very much.
Thank you, sir. Thank you for such an excellent lecture. Actually, you taught like a true teacher by breaking every sentence and word and explaining us the meaning. Because when we read all these definitions and we read all these concepts and we just have in mind that we have to mug up all this, it's not right. It's every word has a meaning. Why it is called as others case, why it is called a recurrent case. And so, like sir taught us, there's a difference between relapse and recurrent TB by the fact that whether you got reinfected by a different mycobacterium or it was the same mycobacterium which relapsed. So every word, everything, if we try to understand like the way sir taught us, so it makes sense. Then everything makes sense. Then even higher concepts make sense when we learn it the way it has been taught today. So what I understand is that in our case, it was very important to discuss because we are giving such a long treatment to the patient. So, like sir said, the orthopedician reference should have been there, and the patient maybe follow up. We have to be very sure about the diagnosis because we are giving a long treatment and we are giving a long pill burden to the patient, and there are a lot of added toxicities. So it is not fair for us to just keep on prolonging the treatment just because we know that it's a bone TB and it's not TB and it requires long treatment. So the one thing, if we are lucky, I think in a EPTB case, if you have a swelling somewhere and if you have, it is lucky that you can get some diagnosis, and that diagnosis is very precious. So if that patient, I know patient by the time they are taking such long treatment, they get tired of being so compliant and they get tired, they have this pill fatigue and they have adherence fatigue, they don't want to come back because they think they are depressed. But we as our doctors, we have to be very cautious that if extrapulmonary TB and we can find some sample somewhere, we at our center also, we are very diligent about it, that if not at one place, we try to get the sample tested for MDR TB and for finding out the resistance patterns at some other site. So that should be our responsibility. That should not be patient centric. And because it's extrapulmonary TB, if we are anyway thinking of fighting and ending TB by 2025 or 2020, 30, and we think extrapulmonary TB and we just think of TB as pulmonary TB and ignore the major component, a very major component which has emerged, which is extrapulmonary TB, which is and not take it as equivalent to pulmonary TB, we can never achieve that goal of ours. So we have to take extrapulmonary TB more seriously because it is more difficult to diagnose, it is more challenging to treat. So taking the onus on our hands is what's taught us, and for that, mind doesn't see what eyes don't see what mind doesn't know. So we have to know the basics, we have to know the right diagnosis, and we have to know when to act, when to refer, when to act yourself, and especially to rule out drug resistant TB, because if the patient was not responding, maybe it was a drug resistant TB case. We just don't know because don't have any proof. So there were a lot of learning from this case, and I would want to, if anybody has any questions, please to the expert or the presenter, please ask your question in the chat box.
So we have one question. This is for the case presenter. If it is turned to subjunct SJS.
If it turns to be
SJS, what will be the approach? SJS?
I think, are you talking about Stevens-Johnson syndrome? Sachin Kataria, can you please unmute yourself?
Yes. We had a case long back which turned out to be SGS.
Mr. Sachin, can I please know which ART center? Because
I'm working in the Lokender Hospital ART center.
Okay, Lokender. Okay. Yes, please go ahead.
Long back, we had a case of iris which turned out to be SGS later on, and we were unable to save the patient.
So SGS, SGS is like a mucosal, it happens more immediately than.
It was a grade 4 case. Ultimately, the patient expired. He was admitted to the medicine department, but 3 days later he expired. So we were unable to work on the protocol of iris also.
Okay. But iris, that's what we are saying, that iris will not happen so immediately as the Stevens-Johnson. Stevens-Johnson is like immediate reaction, more of immediate reaction, and an iris. Iris takes 3 weeks to 6 months and some more gradual onset, and it's not even as severe as Stevens-Johnson. So there's no confusion as such with the Stevens-Johnson. So the only thing we keep in mind is that whenever we get any reactions of skin reaction, rashes, the mucosa should not be involved. The involvement of mucosa is a red flag sign in red flag sign to identify the Stevens-Johnson syndrome. But I would like my expert to answer further.
Dr. Kataria, it's very difficult to understand or correlate Stevens-Johnson with the iris. Iris is the pre-existing disease or new lesion to be appear, which is tuberculosis.
The patient was a known case of TB, followed up 14 days of ATT initiation with signs of Stevens-Johnson. So we had admitted the case.
No, it's okay. It's okay. You can admit it. But thing is, the Stevens-Johnson is a side effect of medicine. Or iris is a lesion which is already exist. So you cannot correlate with the Stevens-Johnson with the iris. Iris is the already has lesion, either old lesion or new lesion. Stevens-Johnson is the side effect most of the time. If a patient is on ATT or ART, then only you can develop the Stevens-Johnson because of the drug side.
The patient was initiated on ATT and he was a pre-ART case. So during that time, we had to take a gap of 14 days for ART initiation along with Ceftriaxone prophylaxis. So we were unable to define what kind of it was, but ultimately it came out to be Stevens-Johnson from medicine department. So we were confused whether it was due to ATT or it was a exclusive case of Stevens-Johnson.
ATT में मेरे ख्याल से कोई भी मेडिसिन Stevens-Johnson नहीं करती है.
ATT में sir, that I just said that ATT वैसे तो any medicine can cause. Although but
ART can.
But you have to understand that the Stevens-Johnson is a drug reaction which happens more immediately, and For iris to develop iris pathophysiology is not a hypersensitive reaction. It's iris pathophysiology is that the patient is improving virally, viral load wise, and viral load is decreasing, his CD4 counts improve. So because there's an immune reactivation in the body, so whatever the occult infections are in the body, like TB is already there, it will manifest itself, or maybe TB, maybe the like a lymph node will expand or enlarge in size, not because of any hypersensitive reaction, but because now the immunity is boosted. So it expands, but it is more gradual than what will happen in a Steven Johnson. It doesn't, and Steven Johnson is more like a skin and mucosal involvement, and it's very fulminant and very severe. Iris can happen anybody, anywhere. It can just be a lesion in the brain which expands. It can be a very high fever which is coming. So it is just very, very broad symptoms that can happen in iris, lymph node expanding or tuberculoma expanding or a fever, not unrelenting fever. But Steven Johnson is like a typical, you get skin reactions. So that's not what typically, there's nothing clinico-pathogenic picture of iris. Iris can be anything. Iris can be just unexplained worsening when the patient is CD4 is improved and viral load has gone down and you're like, oh God, when everything is improving, why is patient getting this new fever? Why is patient getting this new lymph node enlargement? So you're just little confused, but it is a very insidious onset and gradual onset. You're not so alarmed. You're not so you're not panicking when you're getting iris. And even though you just don't know why clinically patient is showing worsened sign and symptom when immunologically he's improving. That's when the problem of iris you come into your mind when you have ruled out the failures of either ATT and ART. But Steven Johnson is a more direct hit, and hit a person with a drug which is hypersensitive to, and it will develop that very unfortunately in 1 to 5% of cases it will develop such a fulminant skin reactions, drug reactions. We see so much common drug reactions with ATT, but very rarely we get Steven Johnson's.
No, most of the जो ciprofloxacin वाला group है, most of them fluoroquinolone groups usually see Steven Johnson. But what you said, within 3 days Steven Johnson was appeared and your patient is died. It's a difficult whether it was really Steven Johnson or not. क्योंकि Steven Johnson जो है वो काफी time देता है. It's not immediately you start with the Steven Johnson and you say that within 3 days patient died. Might have something else also.
Most of the time because your mucosa is breached, so it's super added infections with those Steven Johnson that leads to the fatality. And steroids are the mainstay of treatment in both the places because you have to cut down on the inflammation that's happening. So I hope that answers the question. We'll go to the post-test poll answers. Yeah.
The first question was, the skeleton TB is 1 to 2% of all the TB cases and 10% of the EPTB cases. Then about how much TB involves the spinal column? Option 1 was 40%. Option B was 45%. Option C was 50%. Option D was 55%. The correct answer is option C, 50%. And for the second question, the clinically diagnosed lymph node TB, symptoms and signs of the lymph node tuberculosis plus, it's D, all above, the negative microscopy, negative culture, NAT-based test. So if you have all this,
it means,
along with the
it doesn't
symptoms,
mean if you have a microscopically positive case, it's not a clinical diagnosis. It's a confirmed diagnosis. So question is clinically diagnosed. Clinically means we do not have any AFB positivity in NAT or cytology or in culture. So that if you do not have microscopically positive culture or NAT positive, then and sign symptoms suggestive of lymph node tuberculosis, then you can label as clinically diagnosed.
So now I request Dr. Tanweer, are your all questions answered?
Yes, ma'am. Only I want to know, can we advise for physiotherapy or not?
See, for physiotherapy, you have to discuss with your orthopedician. You yourself should not advise, because physiotherapy is also a specialized management.
Okay.
What type of physiotherapy he or she has to do, then you discuss with the orthopedician, and then with the help of orthopedician, you can discuss with the physiotherapist also. By seeing the lesion, he can advise, or she, whosoever is there in physiotherapy department.
I request all my participants, we have these sessions uploaded on the YouTube channel. In past, we have taken sessions on the Pott spine also, where the orthopedicians have given the consultation and didactic on that. So you may also visit to the channel and see the same cases for the references. And as sir suggested, if you have any doubt regarding the case, please also take the opinion of the orthopedician.
That is more important.
I would like to reinstate what sir is saying. I'm saying that every case is different and sometimes physiotherapy can be detrimental. So like sir said, you cannot just take a blanket message on keep physiotherapy should be like this or should be like that. Because every case is, especially if there's a nerve involvement and you tell your set of physiotherapy to which you had practiced in some other patient, it might be very detrimental for the next patient. हो सकता है case बिगड़ जाए कि जो physiotherapy किसी और के लिए suitable है हो सकता है next patient के लिए ना हो. So every case is different. Especially when the nerve is involved and the lesion, the kind of lesion involved, so you have to refer them to an orthopedician. There's no way that we should ourselves be advising that and make the case worse for the patient.
Yeah, sure. Thank you.
Yeah. So with that, we'll go to the closing comments by our experts, sir, and then we'll close the session.
See, any case of tuberculosis, whether we are dealing with the pulmonary tuberculosis or extrapulmonary tuberculosis, especially with the extrapulmonary tuberculosis, we have to understand how we are going to diagnose it, because once you start the anti-tubercular treatment for any patient, then any physician cannot stop it before 1 month, because if it turn out to be a tuberculosis, then it's a very difficult to stop. We have to continue with the anti-tubercular treatment till the end. So by diagnosing a case of clinical or confirmed tuberculosis, be judiciary, follow the guideline and do accordingly. Thank you.
Thank you, sir. And with that, I thank our case expert also for sharing the case, and big thanks to you, sir, for giving us such an excellent narrative. And it will be available on our channel for us to see later and benefit later.
Yeah. I thank our case expert today, Dr. Lokender, for the wonderful didactic, and I hope all the questions of our participants are answered. I thank our case expert, case presenter today, Dr. Tanweer, to bring out such interesting case for the discussion. I thank Dr. Ananya for moderating the session in such a nice way. I thank my whole team behind the curtain, Ms. Shifa, Mr. Manjeet, for giving us the support. And lastly, I thank all our participants who takes part in the session. Thank you so much.
Thank you.
Thank you all.
Thank you.